system. They've just noticed people on long-term use of heparin, most of the time though, you're going to use it more as a temporary fix. The only one, for instance, the girl who had protein C, she was on it during her whole pregnancy. She would be someone you'd have to worry about with osteoporosis, with the HIT. She had to do it the whole 9 months of her pregnancy. Most of the time, you're not going to be put on it long term if they can get you on Coumadin. And now she's on Coumadin since she's had the baby, since she did have the PE. So even most of the time, they're going to try to get you off heparin. Coumadin is, you know, your most common one that's going to be long term. And probably all of your elevated protimes, you know, 95% are going to be due to that patient being on Coumadin.
Can you not take Coumadin while you're pregnant?
Evidently not. I think the heparin, I think it says in here, doesn't cross the placenta, but the Coumadin does. So, and she had to give herself shots in her stomach every day, and it was the low molecular weight that she was on. So, this is cheaper, and on your test, I don't care if you put it monitored by the PTT or the factor 10A assay. Either one is correct because you can do the factor 10A assay as well. Most labs on unfractionated are just going to do the PTT and see if it's between 60 and 80 seconds. The thing about the low molecular weight heparin that to me seems like the biggest reason they've gone to it, not even though it's expensive, is it doesn't have to be monitored as closely. And I think the unfractionated, the PTT isn't a great test for monitoring, so they sometimes do the PTT level every 4 to 6 hours when they first put them on heparin. The way the book reads, you don't even have to do a regular factor 10A assay on the low molecular weight. There's usually no issues getting into the normal range. So at least anybody who goes to Memorial, I know you do the factor 10A. Yes?
I think the book said something about you could use the platelet count. To test for it.
Platelet count probably and I wouldn't think that would be unless they're trying to monitor for HIT. Because it shouldn't be to monitor a platelet count because that doesn't affect your anticoagulant with Coumadin or heparin unless they develop an antibody. So maybe we can look for that in the book where you saw that. Because a platelet count, the only time a platelet count is going to play a role is if you develop an antibody if you're on heparin. Yes?
Question 10, I think, is why everybody's asking, is because it's asking what is the test that's used to monitor HIT, platelet count,
Oh.
and PTT are all on there.
But that's different. Monitoring, HIT is not monitoring heparin.
Mm-hmm.
Heparin, the level of heparin has nothing to do with the heparin-induced thrombocytopenia. So that's two different questions. That's two different things. What is the question? If I asked, what were you going to monitor heparin with? And if it was unfractionated, what would you say? Just the level of heparin. We're not talking about any antibody that might occur. Because that might only happen in 1 to 3% of the cases of people on heparin. What would you do? If it's unfractionated, you're going to do, and either one is acceptable. I think 90% of your labs are still using the PTT, which isn't the best way to monitor it, because they say, even in the book, you can use a factor 10A assay on the unfractionated. The whole heparin, low molecular weight heparin, they say 10A is what you can use, but you don't have to monitor it as closely. It doesn't cause as many problems with being over. So they might do it the first time they put you on it, then they won't have to keep doing it every day or every 4 to 6 hours. So that's the advantage of low molecular weight. But if they suspect, because the case study on your test, if they suspect an antibody, what's going to happen? That's why you monitor it if you're going to get an antibody to heparin. So the platelet count is if you suspect they have an antibody to the heparin PF4 complex, what test should demonstrate that?
Platelet count.
Because, and the example I give, didn't I give you an example of the patient has like 300,000 And then a couple days later, what do they drop to? That's the and you know they're on heparin. That's the first thing I'm going to say is I bet they got the antibody to heparin.
So do you have to monitor it more closely with the unvaccinated because you're more likely to develop HIT?
No, I think you can develop HIT with either one. I don't think the way most labs are doing unfractionated, the PTT is as good an indicator as the factor 10A assay. So I think the assays are better by doing the 10A. That's one of the reasons you don't have to monitor the low molecular weight as much. PTT, you're affected by so many things with the PTT. The biggest one is your antithrombin 3 level. The low molecular weight isn't affected by that.
Okay,
And-
let me be clear. So if you're just monitoring the heparin, unfractionated or fractionated, like if it's unfractionated, you monitor with the AP, the TP,
Or the
and-
10A,
or the
I
10A.
get, right.
If it's the
Low molecular weight,
then it's just the
the-
assay.
the factor 10A.
But if you're monitoring for HIT, then it's
got
the
it.
platelet count.
Yes, and one of the things you're going to see when you're in clinical, every day you get a CBC. Where's the platelet count on the CBC? So you're not going to even, this is what happens. Usually heme coag are all together in the same department. You're going to be doing, your normal ProTime or PTT if that's all your lab does, if they don't do 10A. But they're going to notice you have what are called delta checks. If I'm running the CBCs and I have a 300,000 platelet one day and the next day I'm down to 30, that is not going out till I figure out what changed in that patient. That's called a delta check. It flags you, it gives you a flag, and you as a tech cannot go turn that off out as a normal happening. You have to say, hey, did they have a bleed, that they bottomed out with their platelets? And the first thing you would suspect if it goes down, and there's something you do, the peripheral smear, remember, if you're going to assess red cell morphology, you're also going to assess platelet number. Because every platelet on different scopes, one platelet equates to 10,000 platelets. So I have 10 platelets, that's 100,000 platelet count. If my scope assesses 10,000 for every one you see under 100 power or oil. And so if I'm looking at my smear and I see platelet clumps, that sends up a red flag. What caused my platelets to clump in circulation? And you're going to see with hematology, it might be because the EDTA, some people clump their platelets with EDTA and you got to do something different. If I see no platelet clumps, and on day one I had 30 platelets when I did my smear review, times 10,000 is 300,000. The next day I only see 10 platelets. That went from 300,000 to 100,000. That's a big difference. You cannot, as a tech, turn that out without investigating. Call the floor, was there any bleeding? And then that's when you suspect HIT. They say, nope, there's no bleeding issues, there's nothing. Then you gotta say, well, what medications are they on?
But the whole reason you're monitoring with either one of them is for the complication in HIT, right?
The only reason you would notice a change in the platelet count, and then you're going to have to start closely monitoring the platelet count. You're going to have to get them off heparin, and then you're going to see if the platelet bottoms out so much, once you've removed them, you may have to give them platelets till their own bone marrow comes up with it. Normally, you're just monitoring the PTT and the factor 10A to make sure that heparin is at the right level to stop the blood clot. Very few people get this antibody, but you got to be aware that they can. And if you're going to see any antibody, I bet you're going to see the heparin-induced antibody over ITP. It's just something you got to be aware of. And that's where communication between departments is big too. I mean, we lucked out at St. E's. We had coag, heme, UA, and serology all in one area. So that was my area. You kind of knew what was going on. So if I was the person doing the CBCs that day, and let's say DJ was the person doing the ProTime PTT, hey, I would say, hey, this person, platelets bottomed out. I called the floor. The only thing they can think of it might be due to the heparin because they have no bleeding issues. They didn't have surgery. They didn't have anything to wipe it out. You got to communicate as well. So it's really going to be between you and the nurse. If they have not actively bled where they could use up all their platelets in trying to stop the clot, or if they're not in DIC, then you've got to start looking at their medications. And the doctor's going to be well aware, if that platelet kind of bottomed out, he better look at that heparin. So there's going to be communication from you and the nurse, but you as a tech have to realize you cannot report 100,000 platelet count if it was 300,000 the day before. You've got to be aware, hey, you can't just say, oh, that machine has to be right. I did make you see, I know it's right. Well, it probably is right, but you got to still let someone know something's going on with that patient, or else it could impact you have to let them be aware so something isn't missed on their end too. What if they don't read their reports well and they don't see that there was a 200,000 drop and they keep them on heparin, it bottoms out their platelets, then they can't clot. And you could have had them removed off heparin that day, and since you dropped the ball in the lab, they didn't read the reports on the floor. So just HIT is just something you got to be aware of, that on some patients they develop this antibody. It's not every single person who's on heparin, so I'm not saying it's going to happen every time, even once a week someone's going to have the antibody. Yes?
You keep telling us that we can do this test to check this, and we can do this test to
Uh-huh.
check this. But don't all of the tests have to be approved through the doctor? Do we have to get approval from the doctors?
Oh, you will not do any tests. There's a thing called reflex testing. That's the only time you have it set up that it'll automatically let you do a secondary test, and I'll give you 2 examples. We're not going to be doing anything without the doctor's approval, and we're not going to be the one telling them to take them off heparin. The doctor, we just have to make them aware, hey, this platelet bottomed out. We're telling you on our end, we don't see anything wrong. We've had it redrawn. It's still that low. Then they have to be aware, okay, if they're not bleeding, if they haven't had anything happen to them that they would have used up their platelets, then they got to look at medications. And anybody on heparin, the physician's going to have to think that it could be a heparin antibody. Okay? But no, we don't order them. 2 cases that we always could reflex to the next test. If I had a negative strep throat screen and ER, we had it set up that it would automatically reflex to a strep throat culture. We didn't have to call the doctor and say, hey, can we order this? It already was, we had it set up. If I was negative on my little rapid test, then I could do the culture. And we always had 2 swabs, so the second swab went for that culture. Now, the other one was with urines. For an ER urine, if we had greater than 8 white cells, not necessarily if we had a lot of bacteria, because if they don't clean themselves properly down there, you might have bacteria from the skin. But if we had greater than 8 white cells, we automatically set up a culture. So we took that urine, and it had to be a clean catch, and we had to handle it sterilely when we used it, just poured over, didn't put a pipette in it. And then we would give it to micro, and then they would do the urine culture. But we already had an approval from the physicians that this is how we're going to handle negative streps, and this is how we're going to handle high white counts on urines. That's a case where you don't have to, the doctor doesn't have to tell you every single one to order it. But you're right, unless it comes from the doctor or the nurse from the orders from the doctor, we are at their mercy what they order. Sometimes, we would be frustrated. How a tech should be used, we should be the experts for the lab. We should be consulted. What would be the best pathway to try to, let's say we're going to do a heart attack. Tell us what you want us to order. Okay, you order a troponin and a myoglobin. If I suspect a factor 10 assay, I would want to know my ProTime and PTT are elevated. So it's a common factor, and I would maybe say, well, why don't we do a 1, 5, 10, and a 2, since it could be a common factor. And in most labs, they'd say, let's start with 1, because everybody has a fibrinogen usually. So we should be the experts of lab, but we'll have doctors come in, and it used to happen to this one doctor. He would come in, and he'd order everything under the sun on one patient. So you might be drawing like 11 to 12 tubes. It was the most we'd ever drawn from one doctor commonly. So let's say you have like an upper respiratory thing going. He'd order a strep, a mono, a flu A, flu B, a cold agglutinin. You might have 5 to 10 tests. And so that's very costly what the patient's going to pay for just to him to try to rule it out. You should have some idea, okay, if it's throat, let's start with maybe a strep and a mono first. You know, don't run the gamut. See, we're not being used like we should be. Just like a pharmacist should be used by the physician to consult, okay, how do we want to handle the heart attack, the heart problem? What medication? How do you want to handle this infection? It should be the pharmacist as the expert with the drugs helping them decide what's the best thing. Well, that's how we should be. We are the experts on lab tests, and we're not used like that. They're trying to get us to go to levels MLT, MT, a master's MT, and a doctor MT. Well, if you don't have the higher ups in the lab utilizing your lab skills as the expert, it's pointless. No one is going to pay extra for a master's MT if they don't have a different job than just running the same test, or a PhD MT. So until we get more respect from the other departments, you know, we're not being utilized for our expertise. And we know a lot about lab testing. Okay, so the low molecular weight heparin, its big drawback is it's expensive versus the unfractionated. But it's more easily monitored, and it doesn't have to be monitored as often as unfractionated. So that's a big advantage. And you really only use the factor 10A assay. And I hope some of you get to see that. And I don't know what you'll see. Probably Lovenox is the most common name I've heard of as low molecular weight. And I don't know how they decide what brand to use, but my daughter's girlfriend was on Lovenox shots. I think that's the most common low molecular weight. But these were just examples of types of low molecular weight heparin. And most of the time, it's not going to happen often. So it's not like every person on heparin is going to get an antibody. But usually, if the problem's going to occur, it's going to happen within the first week of being on it. So that's a good thing. You at least get to know quickly. And hopefully, if it's not till the end of the week, your Coumadin level's at a high enough level. Otherwise, see if you read anything on the PowerPoint. If you can't use heparin and your Coumadin level isn't high enough yet, what do you go to? You remember towards the end of the PowerPoint? What are your other? There's direct thrombin inhibitors. There's other things besides heparin and Coumadin that they're trying to work on now. And what they're trying to do is get them to where they only work directly. If it's not on this PowerPoint, it's on other treatments. Okay? So they're trying to make other options besides Coumadin and heparin. I think on your registry test, you're going to get tested primarily on Coumadin and heparin, because the direct thrombin inhibitors, even the differences of unfractionated versus low molecular weight, I think they're going to stick to the key differences of Coumadin and heparin still. But it is coming that they're not just going to have those as alternatives. Yes?
So Paradaxa and the other ones, those actually act like heparin and Coumadin. They're not just supplements to them?
They're not supplements to them at all. They will stop clotting at different points. So if it's a direct thrombin inhibitor, it might stop it at the 2A. I mean, they're trying to come up with products that only affect the blood clots where it's formed. The problem with streptokinase, when you're trying to prevent the fibrinolysis, you're trying to break down the clots, you have things you can give them that'll help you to break down the clot where it's at. So if your Coumadin and heparin's not working, usually these patients are kept in intensive care, they can give them injections of streptokinase, because what's that, Alvin? Plasminogen form plasmin to break down the fibrin clot. The problem is TPA is the only one that only plasmin just acts on the fibrin clot. You give them streptokinase, urokinase, staphylokinase, it's going to be non-specific. That plasmin is going to attack your clotting factors like 1. Remember, it can act on 1 or the fibrin clot. TPA, what's so good about that, if they give you an injection of that, you come in with a heart attack, it's going to go right for the fibrin clot, and they may minimize the damage to your heart, or if you had a stroke, wherever the blood clot is in your brain, or if you have the blood clot in your lung. TPA is the one they'll choose because it will go to the fibrin clot. You give them the others, it's non-specific, so it might bottom out your factor 1, and you could bleed. So you have to be monitored very closely. They're just not going to give you some of these other therapies without having a very close watch on you. And when you're in intensive care, they may only have 1 or 2 patients they're working with. Not like a whole wing of a floor if you're on a normal floor. So you're not just going to give these extra medications without being able to closely monitor that patient. Because you got to be aware that if they could start bleeding, because if you over-medicate them. I mean, you might have them on heparin, Coumadin, they're not working, so then you go ahead and give them an injection of TPA, streptokinase, urokinase. So you got to be closely monitored. It's not just everybody on normal floors are going to get these extra therapies. Okay, normally if you're going to get HIT, the biggest thing, I think there was a question about who has the lowest platelet count, which type, when you get the heparin-induced antibody. The low molecular weight. Usually those platelet counts fall below 100,000, where with unfractionated you form the antibody. You're still going to be low, but you're not usually going to fall below 100,000. So you're going to get a worse drop if you get an antibody to low molecular weight. And this one, it seems to clear faster. Remember, your spleen can clear these PF4 on the platelet and the heparin complex. When you make the antibody to it, it gets cleared much faster on the unfractionated side. That's probably why the platelet count doesn't bottom out as much. It lasts. That antibody doesn't get cleared as quickly on unfractionated. Yes?
It says no antibody forms to type 1. So how do they screen for it? Just, is that wrong or?
I know. Let me look that up, because they both should have, unless it's a different process, but I thought in both. Let me make sure, because I have the pages flagged on the HIT. It says immune-mediated thrombocytopenia caused by an autoantibody directed against heparin complex with PF4. And PF4 is released from the platelet alpha granules. So that's where you get that. Let's see. It just says low molecular weight heparin can trigger HIT, but much less frequently than UF unfractionated. Yeah, I think we're going to have to take out the no, because it doesn't say that one has it or the other, unless my other book. Let's see what it says, lab evaluation. Functional assays based on the ability of HIT, IgG. Both types of assays have similar sensitivity for HIT. Low molecular weight is less frequent inducer once the antibodies have formed. Yeah, we're going to take out the no, because these both, it sounds like they both have antibodies.
Also, now
Yes.
I'm a little confused because there's question 13 on the test says
Okay.
patients on low molecular weight heparins are more likely to produce low platelet counts. Do you really mean the platelet counts
They aren't.
are lower? Or-
No. Who causes more frequently, the way the reading is unfractionated. So keep it that they both have the antibody, okay? So just take out the no. So they both have an IgG antibody because I can't see it distinguishing, and this is the latest book. So keep it that they both produce the antibody to the PF4, and it is an IgG type, but the one that is more common to produce it is the unfractionated. So low molecular weight is less likely, okay? So that's what it says here. It says, headed underlined, low molecular weight heparin can trigger HIT, but much less frequently than unfractionated. Okay, so
Does a low molecular weight have a lower platelet count though?
when it does, it does.
Because like, the question is more likely to produce a low platelet count due to HIT.
Oh, no. I thought it was two separate questions.
No, that's why the question is a little confusing, because I feel like more likely to produce a low, like,
The one, okay, when you get, if you get an HIT from either one, who has the lowest platelet count? The low molecular weight. But which one is less frequently to cause HIT? Low molecular weight. Okay, so read the question and we'll see which one, that's two different things. That's two different things though. So read the question and we'll see, I think it's asking who has the lowest platelet count.
patients on low molecular weight heparins are more likely to produce low platelet counts due to HIT than if on unfractionated.
And that is true, right? Because they get the, if you get an HIT with low molecular weight, they're gonna have a worse platelet count. But right underneath that, I want you to write also, who causes HIT most? Which patient, which heparin? I would write that statement, so when you go study, unfractionated heparin is more likely to cause HIT.
They also cause, I mean, the platelet count is still low, it's just not as low.
Right. It clears faster. That antibody clears faster, so your platelet count doesn't drop as bad. They say this one persists, the low molecular weight, so that platelet count keeps dropping. So that's two separate things, so you got to be aware of the difference. Unfractionated, you're going to get more chances of having the antibody, the HIT. But if you get an HIT with either, the lowest platelet count is with low molecular. Okay? So I'd write that other statement underneath because it's two separate things.
So, I'm sorry.
Yes?
So then how would you monitor it? Because you could do a platelet count for the
HIT, you want to monitor it with platelet count. Does everybody understand if you get HIT, that has nothing to do with monitoring heparin levels.
Yeah.
Okay, that's separate things. To monitor a heparin level on the unfractionated, you use the PTT or the factor 10A. To monitor low molecular weight heparin, you do the factor 10A. If you suspect an HIT, what's going to change? Your platelet count is going to go from normal and it's going to go below normal.
And that's for both unfractionated
Both.
and
But which one? This one wouldn't get below 100,000, but it's still low if it's 120.
Yeah.
Okay?
Yes.
This clears faster.
Okay.
The spleen, because the antibody doesn't persist. Low molecular weight, the antibody persists and that platelet count keeps dropping. Okay, but this is something I think you're going to be aware, you're going to see, is the HIT. So normally, with HIT, just kind of like the lupus anticoagulant, bleeding isn't the problem, thrombosis is. So they're both weird situations. The lupus inhibitor, when you don't correct with normal plasma, and if you get a heparin-induced antibody, the problem for the patient is usually not bleeding, it's thrombosing. So that was in the chapter with thrombophilia. So they're kind of unusual. And there is a heparin antibody test you can test for. Once your platelet count starts dropping from normal and you're on heparin, they can actually you order a test for a send-out for an antibody for heparin-induced thrombocytopenia. At our level, what are we going to monitor at most normal hospitals? Just the platelet count. And what's your first thing they're going to do? Take them off heparin. Then you got to look at something else. If your Coumadin isn't a high enough level and it's not for some reason you are not getting in the INR you need to, they've got to look at other ways to stop that blood clot. And so you got to know your normals. So remember for your finals, 60 to 80 seconds is normal for the PTT if you want to be your PTT if you are just monitoring unfractionated. So if it's below 60, what are they going to try to do?
Take them
Up
off.
the dose. If it's above 80 seconds, what are they going to try to do? Lower the dose. What happens if they keep increasing the dose and nothing changes? What has decreased so much that the heparin is ineffective? Antithrombin 3. Remember, the longer you're on heparin, antithrombin 3 bottoms out. You've got to get them off the heparin and onto something like Coumadin. So it's a tricky thing. I mean, you've got to have close involvement with your pharmacist when a patient's anticoagulation isn't working. Now the factor 10A assay, the 0.35 to 0.65. Yes?
Why would you up the dose if it was below 60? Because that's just going to make it clot faster. That would lower the clot.
Below, up the dose makes it a clot slower. If you give them heparin, they're not going to clot faster. I mean, you're thinking the reverse.
Yeah.
I mean, if it was greater than 80, you are going to lower the dose. But then there gets to a point, it doesn't matter what you do with that dose, your antithrombin 3 keeps dropping the longer you're on it. That heparin is ineffective. So you've got to get them either up to 2 to 3 INR and just put them on that, or you've got to find another method.
What
Yes.
does the IU stand for in the IU?
International units. That's used a lot in chemistry, and Barb will go over that. A lot of chemistry results are IU per ml, and it stands for international units. Okay, so let's go over the treatments, and then we'll go over your test, and then we'll review. So the biggest thing is you've got to be aware of a thrombocytopenia due to heparin. That's probably going to be your biggest reason, more so than ITP. Okay, now this has a combination of what you do for bleeding and thrombosing. So in blood bank, you're going to learn about blood products. If you're actively bleeding, and they were just telling me, Eric and Jack, because now they're working at St. E's, there was a case in blood bank. This person was bleeding profusely. I don't think it was from an aneurysm. I think it was a surgery gone bad. One person in blood bank, and they have a new protocol call for stat blood bank, where it's like emergency release. You give ONEG. If you're given a lot of blood products, you've got to give so many units, so many FFP, and so many platelets. So they were give every 2 units, then they had to give a little packet of FFP, and then every 6 units they had to do platelets. So this one person was probably dealing with 10 units of blood, 5 units of FFP, and 1 to 2 units of platelets, all by herself on one patient. So these products for treating can be products that might treat if you're bleeding, and products you might treat if you're thrombosing. Okay, so the treatments encompass both. Okay, the thing with Plavix is something you're going to see. The name is clopidogrel. I've only heard it as Plavix, but that was what it was in the book. How does aspirin work? And so it stops the formation of TX, and it doesn't allow what in the platelet plug formation? The release reaction, okay? So Plavix blocks ADP. When do you, yes?
TXA2, is that thromboxane?
Thromboxane A2. So Plavix stops ADP receptors. So you get ADP released when the vessel is damaged. You get ADP released from what in the platelet? What granules release the extra ADP?
Dense?
The dense granules. So Plavix works a little differently by blocking ADP. So you should at least be aware that Plavix, I think you're going to hear that a lot as a treatment, not just someone on aspirin. They're going to say, oh, but, and that was one thing the lady, the biology, she was on Plavix as one of her treatment methods. Okay, so that's something that I think you're going to see more commonly than just, oh, take an aspirin a day. A lot of people will be put. We already know heparin, you can do unfractionated or low molecular weight, but low molecular weight is more easily to monitor for the patient. Even though it's more expensive, I think you're going to see more hospitals going to low molecular weight. The problem is, what's a big negative? It's injection. It's not oral. You either IM it in intramuscular or an IV, or, you know, I think we see a lot of IVs, continuous IVs, when a patient is really bad. Okay? That's a big drawback, though. I mean, if you're an outpatient, you got to be able to give yourself a shot and be able to do it correctly. Draw up the medicine correctly, make sure you inject just the right amount. So there's a lot of problems with relying on a patient, especially if the patient isn't, you know, mentally well, if they don't have a good caregiver that can help them. The Coumadin, we know the drawback, it takes too long, but it's easy, it's oral. And sometimes it's hard to monitor. If you don't have good diet, yes.
I just wanted to clarify on
And
this.
really, probably 3 to 5 is probably the days.
Okay. Yeah, that's what I was
Yeah,
curious about.
3 to 5.
I
I think
think
the,
it's on our test.
yeah, I would say 3 to 5 days. I've seen it, different books say different things, but this book says more 3 to 5 days. But the INR on normal anticoagulant therapy is 2 to 3. The only reason you'd be higher is if you have a lot of problems and you've had recurring MIs or you keep getting a deep vein thrombosis. Then they might want it between 3 and 5. But normal people, it'll be 2 to 3 the INR they want you to get. Okay? Factor 10A inhibitor, this is something, where is 10A in the cascade? It's the beginning of the common factors, right? So they could inject you with a factor 10A inhibitor, and 10A is not going to get to do its job in forming more clots. So these are other therapies they could try if your heparin maybe isn't working or you've developed an antibody. If you're having trouble getting your Coumadin in the right level, then they might have to go to something else. Yes?
That's why your platelets will come together, because it's obviously platelet.
The platelet is just because there's for the HIT, an antibody formed because PF4 from the platelet bound to the heparin and your body saw it as foreign.
But the antibody
Is-
is 10A, correct? That's why we do a 10A assay for it?
No, the 10A is your main factor before, 10A is your first common factor. So remember, heparin, what does heparin inhibit? What's heparin inhibit? Everything but what?
Oh, 7.
And the first 2 factors it does the most, 2A and 10A. So heparin, if they say, okay, you can't take heparin because you develop an HIT, we got to find something else to help you, then they could give you an injection of a medicine that has a factor 10A inhibitor. So they're just going to go right, remember how we said even snake venom start clotting? That's on the clotting end. They'll go straight to give you 10 and they'll form the clot. They'll bypass the cascades. Well, you can do an inhibition too. So if I give you a factor 10A inhibitor, that's telling me heparin wasn't working or you formed an antibody. The Coumadin level maybe wasn't good enough. Okay? So this is just as an example of another medication to stop clotting. So, and the nice thing, there's a low HIT risk. So they don't have to worry about you developing a platelet antibody that bottoms out your platelet if they give this medicine. So this is a anti-clotting medicine, okay? And that's just a type. I think still on your registry, they're still going to expect you to know stuff Coumadin and heparin. A lot of these other things are newer therapies that I don't think you're going to get any direct questions on them. Now, thrombin, what factor is that? So if you don't want to act on 10A to prevent clotting and stop it, they can go to 2A. That's what thrombin is, okay? That's the one that leads right to fibrinogen becoming the fibrin clot. Why is it good that it doesn't require antithrombin 3? What happens the longer you're on heparin? Antithrombin 3 bottoms out. Well, this one, if you give an injection of this, they don't have to worry about your levels of antithrombin 3. It'll work well. So this is another. These are examples of what's coming as other uses besides heparin. So you have a factor 10A inhibitor they could inject you with, a factor 2A inhibitor they could inject. That's what they mean by a direct thrombin. It'll stop 2 from doing its job, which is what? Break the fibrinogen into the fibrin clot, or 2A. Yes?
What does it mean by not neutralized by PF4? Like the way that heparin.
Remember the HIT? It was a big PF4 bound the heparin, and then that got identified as foreign, and you made an antibody. But PF4 has no involvement. If you give this, it won't touch the direct thrombin and cause a problem. Now, and I don't know, we in the lab don't know what they're all giving them on the floor, because there's not a test for this that we do. What do we do? The PTT, or if you're lucky enough to have a 10A for low molecular weight heparin, we will just probably be doing the PTTs, but unless we know from the nursing floor that they're on these other inhibitors, we won't know, because for us, we're just doing PTTs or we're doing 10A. A lot of times we don't know all that a patient's getting treated with, especially even when you talk about aspirin and Plavix. If you did a bleeding time or a PFA 100, unless you ask, if it's not on any form, you don't know. Yes?
If you're taking a thrombin inhibitor though, wouldn't maybe your PT and your PTT be low?
If you are, so you're clotting excessively. Okay, you think if you're clotting excessively, your PTT and protein might be shorter. Because we see that happen when you have a blood clot in the tube. If that clotting is started and it just started, I would know to rim my blue tops, because I put the PTT on, instead of being 28 to 30, I'd get it down to 20 and 21. That sent a red flag to me. I'd get my little applicator stick out. Before I turned out any result, I'd rim it, and many times I had a little tiny clot that had started the clotting. So your PTT is only going to be shortened if you're not on any medication and you're having blood clotting problems.
So this will even it out, so it should be more.
Well, and I don't know if they put you on this, if they expect it to be a longer. I would think if they're trying to prevent you from clotting more, it's gonna be treated like being on heparin, the 60 to 80 seconds. I would think it's not working if I'm normal. I'm already having clotting issues. If I'm a person with blood clots, okay, and they don't give me any heparin, I'm going to have a normal PTT time, but I'm going to still keep making that clot. Well, the same way you would think, if they don't give us any other test that they monitor it, the PTT should get more prolonged if it's not having fibrinogen become the fibrin clot, right? You're blocking thrombin from triggering fibrinogen to the fibrin clot. So in vitro, that shouldn't be clotting as fast if you're stopping 2A from doing its job. So technically, you should see that PTT increase, because you're not letting fibrinogen become the fibrin clot. So you should see an increase if it's preventing the fibrin clot from being formed. Because remember, thrombin is 2A. You can't break the fibrinogen into the fibrin clot without it. If you're saying I'm blocking all your 2A, you shouldn't have a normal PTT or proton. And in the lab, unless you have a 10A, that's about all we have to monitor the clotting is that proton PTT. So these are just other medications that they're evolving to, because you see there's problems with heparin and there's problems with Coumadin. These are just examples. I mean, those are just names. Depends on the company who makes them. And the other thing you'll find out there, especially in doctors' offices, I don't know, we have a friend whose daughter's a pharmaceutical agent. Sometimes it's the best salesperson to get whatever drug they're promoting for you to buy and use for your patients. So all of these may work just as effectively, but it might be, what that hospital decides they want to use better from whatever rep comes to them. So sometimes you might have equally good, in this case, direct thrombin inhibitors. It's your choice of your physicians and your labs, and sometimes Who has the best salesperson? Because this girl has to really study the drug reactions before she tries to promote them using it for their patients. And you might have different lines of work, from a general GP person to a urologist to cancer drugs. So whoever knows their stuff the best, that can do what the doctor needs. Sometimes it's how the drug, reps get their drugs in there. Now this is not for stopping clotting. What would you give fresh frozen plasma for if it has all the clotting factors? If you're bleeding. So at least flag it. This is the first thing, and we saw when we did factor deficiencies, most of them you can give FFP, but probably hemophilia A, you're going to do the concentrates. Hemophilia B, you're probably at least going to do prothrombin complex. But FFP is the go-to product if you're bleeding and they got to try to stop it. And like the emergency procedure St. E's just had, where the one girl was working blood bank by herself, they were going through FFP rapidly because there was a profuse bleed and they didn't know what factor was the problem. They were just replacing all of them. Now the other problem with FFP is if you have a liver disease that's not going to get better, the only factor that is not made in the liver is 3. So that patient, you can do some short-term help, but if they can't fix the liver problem, you're going to be out of luck. And a lot of times you end up bleeding from GI bleeding. You can bleed pretty well from anywhere if they can't overcome your liver disease. But FFP, and it should be the type you are. If you're A, you should get FFP from an A person, and so on with B and O. Platelets, they don't have to be ABO compatible, so however they manufacture them. Some patient can be a pheresis donor. So I had a friend who was a B pos, but the biggest thing they used her for, she'd go in, give her blood, and they'd take out the platelets, and then they'd put back the rest of her blood in another line. And she did that, I don't know if you can do that every 6 weeks, kind of like blood. So platelets they must have a very purifying process that you don't have to be type specific. So they're not going to worry about you making an antibody to that platelet. So FFP is not as easy. And what is the problem? What do you have in your plasma if you're A? What antibody? Do you remember what you have? You have the opposite, anti-B. So if I give B FFP, or and there happens to be any impurity, like they didn't get all the red cells out, it could be a reaction to that product. So in blood, normally you're going to give the type you are, and only give O neg if it's an emergency. If you're A, they want to give you A pos. They don't want to just give them an O. It's no big deal. You try to always give what they are. So platelets are to help bleeding. Okay? So we've had platelets and FFP. Yes?
Why did your friend donate platelets every 6 weeks?
She just was nice and wanted to do more. It's a big deal. I am not a regular donor, which isn't good because that's in the summer they have trouble getting products. And it's easy to get packed red cells, but to get platelets, they can do a lot from whole blood as far as getting the FFP. They can separate it out and save red cells and take the plasma part and then make the FFP. But platelets, it's a special process, and you have to sign up to be a platelet donor. She was just nice and offered to be more than just a packed red cell donor.
It just confused me that they put it back in her. I figured they would want the blood too.
No, she specifically was just to do platelets, and they called her whenever it was ready again that she had made enough. So they had a protocol, and she was on their donor list. I remember we had volleyball one night. This was back when we were in our 20s, and she had just given, and she shouldn't have been having any activity for 24 hours. And she went ahead and played and had blood coming out. And it was just nice of her to be a donor. Are any of you guys regular donors? I gotta admit, are you?
I used to do plasma twice a week.
See?
I passed out and they're like, okay, you can come back.
Wow, so you could give that, and did they give you back the rest of the blood? So usually when you're doing a set product, they can give you back your red cells. But yeah, so it's just people that are very nice and giving, and she'd been in the lab environment, so she was around patients that, you know, she saw on a regular basis drawing them, and she just decided that was something she wanted to do. That, I mean, I don't know anybody else personally that is a platelet donor, and that was her big deal. They would always call her for that.
Would donating platelets or plasma be affected by mad cow disease or something like that?
I mean, you're saying if you set disease,
They
or?
won't accept any of my blood because I was in Germany during an outbreak of the mad cow disease.
Well,
So they
they're
won't
going to
know
be
how to
picky
cure
if
you.
you're out of the country for a lot of things. You, as someone who would go to Africa, they're going to think twice about it because that's where a lot of HIV is. So it's not just, that might just be one particular disease that affected that area at that time you were there. They're going to be picky about any travel out of the country if there's anything they're known for, from malaria to HIV. So that was just an example.
Yeah, but is that going to be a factor if you would donate plasma or platelets or something like that?
They probably would be picky about having anything from you. You know, because there's certain, anything out of the country, they always have the questions of asking. And I think they're even picky about tattoos. So and they test your blood now that it's safer than it ever has been. Like back in the 82 when I stuck myself with the needle, we didn't even know about HIV. So I was just fortunate, and you didn't do your hepatitis B vaccine, so I had to get the gamma globulin shots because this guy got a lot of transfusions. And so then I bet it was in the next 5 years, HIV was everywhere, and you had a lot of people getting it because the testing wasn't as good. So we're fortunate now, you can get safe blood products compared to between 80s and 90s. That was, you know, I didn't want to be stuck again by anything, and it was my own stupid fault doing it incorrectly. So I learned the hard way, and I was just fortunate nothing happened. You know, I had to be tested for all of them, HIV, everything. Vitamin K is another one you want to counteract a high INR, and that is pretty fast acting. So vitamin K, FFP, and platelets are more to counteract bleeding. And your direct thrombin inhibitors, your factor 10A, your heparin, your Coumadin are more to counteract thrombosing. Okay, but they're all therapies for hemostasis. And we already know the best one of the fibrinolytic agents, because we know what's their job. Convert plasminogen to plasmin. Okay, TPA is the best one of the 4 listed because it goes directly to break down the fibrin clot. It doesn't go to act on factor 1. These are more nonspecific, and they're not going to be as dangerous to you on acting on your factor 1. So that's one of the reasons a lot of times patients with any kind of blood clot in ER, they give them an injection of TPA right away, and it usually minimizes the clot. These all have to be monitored closely. They're not just heparin and Coumadin. If you're going to add injections of like the direct thrombin inhibitors, the 10A, any of the fibrinolytic agents that convert plasminogen to plasmin, they need to be closely monitored by whatever nurse has them as their patient. So usually it's intensive care patients. And sometimes we'd say, hey, wait a minute, this patient is greater than 100 on their PTT. And it'd be a couple days in a row, and we'd call the floor because it'd be a panic. Oh, yo, they're not just on heparin. We're trying to get them their drugs monitored because we were having trouble breaking down the clot. And then these are just some experimental ones that they're looking for other treatments besides Coumadin and heparin. That is, you know, what's on the forefront. And, you know, hopefully it'll be better what they have in the future than Coumadin and heparin. Okay, so let's go through the test, or pass them up, and then we'll go through the test. And it's just worth 36 points, so it won't be, so pass them up a minute, and then what you'll do is you can't use a pencil. You will do a pen, and you will put the initials on whoever test you get. And then I'll just write down the grade and I'll give them back to you before you leave, so you have the test.
You said 16 or 15? You said who? You said we're putting our initials?
Your initials on the top, and you should be doing this with a pen. Not,
Do you have an extra pen?
yes, I do. I have a red one and a blue one.
Thank you.
There you go. There you go. Okay, so put your initials at the top right, and then you'll give them back to the person, and then you guys will pass them in to me, and then I'll just write them in the book before you guys leave. Okay. Number 1, therapeutic range for Coumadin is a 2 to 3 INR, so that is true, A. 2, cranberry juice and alcohol can increase the effects of Coumadin. That is 2A. 3, FFP or fresh frozen plasma can be used to treat thrombosis. That is B, false. You know, next to it, put treat bleeding. That way, I don't care if you write that in for them, because when you go study the test. 4, Coumadin is fast acting and heparin takes 2 to 3 days to affect coagulation. That is false. If you want to put, it's the reverse. Number 5, heparin was developed as rat poison in 1948. That is false. That is Coumadin. Yes.
I was doing some self-study and I noticed that one website said that it was discovered in 1941.
Yeah, I just.
Was it developed then?
Yeah, I probably just went with what the book said. So I would probably just base it on whatever your book says. Number 6, low molecular weight heparin goes with A, inhibits 10A primarily. Number 7, 60 to 80 seconds goes with B, the PTT, normal for a patient on heparin. 0.35 to 0.65 international units per DL is D. That's the factor 10A normal range. Number 9, unfractionated heparin goes with C, inhibits 2A primarily. Number 10, I'll give you an either choice. When you're monitoring unfractionated, if they put A or C, it's correct, because you can do either. Okay? So 10 can be A or C. Number 12, a patient had been on heparin for about a week. First platelet count was 300,000, then 2 days later 30,000. You would suspect C, the HIT. Oh, 10 was either A or C.
Oh, okay, I'm sorry.
Yeah.
I have a question about that. But I thought the question was asking if it's monitoring HIT
Then you said it was.
and not just
Oh,
heparin.
I'm not even reading my own question.
Okay.
It's D.
Okay.
Sorry. Yeah.
I know, it's like.
Sorry.
yeah.
For the complication of HIT, I didn't read it past the first line. So 10 should be D. You're monitoring HIT.
So what does it mean that it's already formed? That, I mean,
That question is
it doesn't
very
say that the
confusing.
patient has already
They haven't
gone into
thrown
HIT. It just says that you're monitoring.
for a potential complication.
For the complication of thrombus, you're not going to do a PTT or you're not going to be a 10A. If you're worried about them developing HIT, you're going to look at the platelet count. So the platelet count is the correct answer if you're worried about HIT. The PTT and 10A would not give you any information on the complication of HIT. If you're just monitoring heparin, unfractionated or low molecular weight, then you use the PTT and the 10A, okay? So since we're worried about HIT, it's the platelet count. 12 should be C, HIT. 13, we already discussed, you will have a lower platelet count if you get HIT when you're on low molecular weight heparin, so that is true. 14, the one that isn't about Coumadin is B. Coumadin does not act on thrombin and factor 10A. 15, the one that is not true about heparin, it doesn't do all, it could, if I said 2, 9, and 10, you could have said true, but it doesn't do anything to 7. That is your vitamin K dependent factors, that's your Coumadin. So 15 was C, 16, vitamin D isn't a choice of a therapy, so 16 is D. 17 is the factor 10A assay to monitor just heparin use and level. 18, why do you need both? And it's D. Coumadin takes this long to produce its full effect. And 20, if the patient, yes.
You said,
Go ahead.
you said 16 and 17 is D and C?
16 was D, vitamin D, and 17 was C, the factor 10A assay. Okay? 18 is D, Coumadin takes this long to produce its full anticoagulation. It takes that long to get to 2 to 3 INR. And 19 was the same question you had on your previous test, and it's A, it reduces interlaboratory variability for the INR. And what else, if you're on Coumadin, is dependent on vitamin K that you got to monitor if you start having problems with Coumadin? Protein C. So protein C and S, that's a tricky thing with Coumadin because those are your natural inhibitors. 24, another name for Plavix is clopidogrel.
Wait, what's 20?
Protein C, B. Sorry, I didn't tell you the letter. 22, 3 characteristics of direct inhibitors. They were straight from your PowerPoint. I had listed can inhibit free and bound thrombin. You don't need antithrombin 3. You don't bind clotting factor. Let me find it on the PowerPoint. Anybody have any other ones?
Not neutralized by PF4.
What was the
Not neutralized by PF4.
direct? Not neutralized by PF4. Act by binding to thrombin and not allowing it to bind to fibrinogen. Inactivating thrombin that is already bound to fibrin. So hopefully they had 3 of those. Yes.
Something general such as prevent clotting.
But that's okay, because that is your whole thing, the whole purpose of giving them. When would you use vitamin K as a treatment?
To counteract the high INR due to too much Coumadin.
Right, too much Coumadin, maybe they had a panic INR of 5. The Coumadin level was too high, so it's a great way to bring down too high of a Coumadin level. And then give 3 experimental blood thinners, and that was directly from here. And you had Pradaxa, there was Rivaroxaban, there was Edoxaban, there was Apaban. So those 4 were on your PowerPoint slide. So did you at least have those 4? Or if there's something else you had? Because that was directly from the PowerPoint slide. And then you're on the formula for the INR. So they needed to at least show you the formula. They should have at least said 13.5 over 12.5 to the ISI of 1.81. So they get a point off if they don't show that. Because it says give the formula and complete the question below. So it's -1 if they didn't have that. Yes.
They wrote it out, but they didn't put the numbers in.
Did they write out the formula? Like what did they say?
They put INR equals the PT.
Okay, but they at least gave the actual formula.
And
so
then they gave the answer.
it could be that way too. So you could have patient pro time over the mean of the control, you're like level 1 or normal, to the ISI. So they have to have one of those, okay? Because you need to know the formula. And then, what is the INR?
1.15.
1.95 equals 2. And so,
1.15.
No, cause I got 2.
I got 1.95. Anybody got a calculator out?
Yeah, I got 1.
1.15.
I had got
Just someone, because I had used some, I didn't have a fancy calculator, but I used Donna's, and so you put them in parentheses and then you did to the power?
Yeah, I got one.
1.149.
Okay.
1.149.
Okay, equals 1.1. Okay, so then what is the normal range? Is the INR, first question, is the INR good for Coumadin treatment? No. Is the what is the normal range?
2 to 3.
And then what should the physician do?
Someone said increase the dose.
Increase the dose, increase Coumadin. So somehow you needed to see they take more.
What
Yes.
about, you were saying earlier, you can just watch their diet and like take them off.
If someone change their diet, like they were worried that they were eating too much stuff with vitamin K, I'd accept that too.
What if they put the wrong range?
So
It's 2 to 5.
it should be 2 to 3 for the range. That's normal range. The only time you ever go higher than 3, and that's just -1.
Just minus.
Okay? Yes.
Result is empty, leave it -1.
So they don't tell you at all what the INR is?
No, should the physician do after obtaining?
Then just -1. Okay? You'll get 6 points if you got everything right, but each little piece will just be -1. Okay? So then tally up the points and then give it back to the person whose test it was first.
You said it's worth 36.
36.
And multiple choice is just for 1.
Yeah, mine are always just worth 1s. Barb's and Diane like to do theirs worth 2. Okay. And then you guys can just, I'll be trusting and you can just tell me what your score was or come and write it down for me. How
I
about
messed
this?
up on that one,
Yeah.
but I didn't count it.
Put your initials and write your score down for me and pass this around. Okay? So that would be just 36 points. That's all I put in Blackboard. It was 36. But when you gotta pass the class with the 74 average, it's only on the first 5 tests. It can never be on take-home stuff. Because everybody should get, a great grade on take-home. So, because honestly, if you have trouble passing the theory on one class, you're gonna have trouble passing the theory on the whole program.
Deshaun.
So we gotta have
Give me
strict
this.
rules on
You supposed to
passing
put
the
your-
theory.
Your initials and
Oh.
what your grade was.
Yeah, and then now we've got like 30 minutes. So the big focus for your final will be all your tests. So you got all your tests. So you'll have 6 tests. You always have your PowerPoints and your study guides. But I want to break up into groups, and we're still having people struggling with the substitution studies. So there's a few points that I know will be on the test that I want to hit hard. So count off starting 1, so 1 through 4.
2. 1.
2, 3, 4. 1, 2, 3.
4.
1. Okay, so the 1s are up here. So remember what your number was. 2s are back at Jen. 3s are back at Elishaba. 4s are by Tashawn. And you're going to work in teams because I got to figure out how to do better about these substitution studies, and maybe you guys can help people who are struggling. So pass